Hey guys, this is Dr. Aman Setiya, medicine faculty at LNX. So today we'll discuss some of the important topics like that are having high chance to be asked in INI-CET exam. So basically in this discussion, we'll be focusing on repeats and expected questions. So remember, we never stop. So again, like exam is about some repeated topics, so that we need to discuss. Then some expected questions. So like which are high yield in latest edition of Horizon. So it will be like an amalgam of many topics. So we'll study this in I can say less time. So this will be like a good source of your revision. So starting first, I'm saying from past 3 attempts, they're asking question on pneumonia treatment. So if I tell about pneumonia means like prognosis in pneumonia, you can judge by a score. That score is called CURB 65 score. CURB 65 score. So each score we will give 1 point. So C is confusion. C is confusion. Then this U is increase in urea. Urea means BUN, blood urea nitrogen. So when you can notice like BUN is more than 7. R is respiratory rate. So there is increased respiratory rate which is more than 30. And B is BP. BP means when systolic blood pressure is less than 90 and diastolic is less than 60. And 65 is age of the patient. So for each we will give one score, and based on the score we will decide like whether this patient need an outpatient treatment or inpatient treatment. So remember, score is 0. So this patient will be treated in outpatient department. If we have score in the range of 1 to 2, then we need to admit the patient and treatment in the ward. And whenever you see score a value of 3 or more, then this patient will be admitted in ICU. The question which they're asking is, if you focus on the treatment part, again this is a screenshot from Harrison, you can see like we have to see whether this patient is outpatient or inpatient. So in outpatient, what we are doing, understand this, in outpatient we are treating this. Suppose if it is a person who is previously healthy and no antibiotic use in past 3 months, in that case we need to use a macrolide, like we can use clarithromycin or azithromycin. Then or alternative to this will be doxycycline. So you have to remember macrolide. Then suppose if a person who is having comorbidities or antibiotic use is there, in that case we can use respiratory fluoroquinolone, like we have moxifloxacin, payfloxacin. These are the respiratory fluoroquinolones. Then understand this, along with this or other than this, we can use high dose amoxicillin. So like this is one question which came in one attempt, like outpatient department, what you can use. So remember, it is macrolide. If there is, I can say, past usage of macrolide or another antibiotic or comorbidities, then we'll use respiratory fluoroquinolone. Then again, in last attempt, there was a question like how you will treat inpatient non-ICU patient, means when a score value is in the range of 1 to 2. CURB score is 1 to 2. Here CURB score is 0. In case of this, we will use a respiratory fluoroquinolone, right, and a beta-lactam. So we can use ceftriaxone or ampicillin. In patient department, this was question also asked in exam. We will use a beta-lactam, like ampicillin sulbactam combination, or we can use cefotaxime. And sometimes they can ask you like a question on, even this question also came in exam. If pseudomonas is a consideration, then we will use beta-lactam, which are acting on pseudomonal, means we call them anti-pseudomonal penicillin, like piperacillin, tazobactam. So these are the MCQs that they ask again and again. And so expected question from this list will be, if MRSA is considered, in that case we will add linezolid or vancomycin plus clindamycin. So this is something which you have to remember. So always, like in past 3 attempts, they're asking 3 different questions. So this will be the 4th expected question from this topic, like treatment of pneumonia. Now coming to what other things they can ask you. So I am saying like they're asking you a question like they will give a clinical case and they will modify this. What will happen to patient whenever person suffering from diarrhea or vomiting? So just try to understand this. Whenever there is a diarrhea or vomiting, this will lead to dehydration. So it can lead to dehydration, and because of dehydration you will notice. So whenever there is dehydration, this dehydration will stimulate your RAS system. renin, angiotensin, aldosterone system, and because of this there will be increase in aldosterone. There is increase in aldosterone. Now understand, whenever there is increase in aldosterone, this will lead to sodium. This will lead to H positive ion and potassium. H positive ion and potassium excretion. So when H positive ion excreted, what will happen to this? So this dehydration, understand, it is basically leading to contraction of your extracellular fluids. That's why our RAS system get activated. So the result will be, there will be hypokalemia with metabolic alkalosis. Hypokalemia with metabolic alkalosis. Now understand, patient will also have one more thing that is called hypochlorohydria, or I can say hyperchloremia. Means it is because when you are vomiting, so with vomiting, your chloride will also be removed. So that is leading to hypochloremia. So this question came twice in exam. Metabolic changes that we see in a patient with diarrhea vomiting will be hypokalemia, hypochloremia, and metabolic alkalosis. So hypokalemia, metabolic alkalosis, it is due to RAS system stimulation, and hypochloremia because when you are, I can say, vomiting out, you are also losing chloride. So this is something which you have to remember. Now they ask you names of different antibodies in rheumatological condition. So remember, ANA is the first antibody that we check. So ANA is the first antibody. So this is the antibody that we use for screening purpose. So when we want to screen whether it is SLE or scleroderma, first antibody that we check is ANA. Then they ask you question on specific antibodies. So what are list of specific antibodies? So understand, anti-Smith. Anti-Smith is most specific body. Specific for SLE. Then we have anti-dsDNA. Anti-dsDNA, this is also a specific antibody, but it is not as specific as anti-Smith. This is actually an antibody which can correlate with activity. Correlate with activity means this will decide prognosis of disease. Then SLE, sometimes you can see like anti-phospholipid antibody, or I can say anti-cardiolipin antibody. Anti-cardiolipin antibody, or we can see like anti-beta 2 glycoprotein. So these are the antibodies where we see in a patient of APLA syndrome. So APLA can also be, remember, most common cause of secondary APLA is SLE. In SLE, so basically I'm talking about first about SLE. In SLE we can see sometime anti-ribosomal P antibody. Anti-ribosomal P antibody. So remember, P for psychosis. So this is responsible to cause psychotic feature in SLE. And if you have anti-neuronal antibody, or I can say anti-glutamate, this antibody is responsible for neurological feature, CNS features in SLE. Then I can say in SLE we can develop antibody against RBCs or erythrocyte. So these erythrocytes, so this will result in AIH, autoimmune hemolytic anemia. We can have antibodies against platelet. This will cause TCP. That thrombocytopenia is called ITP. So immune thrombocytopenic purpura. Sometimes we can have anti-U1-RNP. Anti-U1-RNP, understand, it's an antibody that we see in MCTD. MCTD is mixed connective tissue disorder. So there are some conditions where you can see 2 or more autoimmune in one person. For example, SLE with rheumatoid arthritis or SLE with scleroderma. So that's what we call this MCTD. There is one more condition similar to this MCTD. We call this overlap syndrome. Overlap syndrome. So just try to understand this. In overlap syndrome, you will not see these antibodies. So in overlap syndrome, anti-U1-RNP is absent. So just try to understand this. How we differentiate MCTD with overlap syndrome. Both condition will have 2 or more autoimmune condition. There will be overlapping features. So in overlap syndrome, anti-U1 RNP is absent. In MCTD, it is present. Then I can say a person who is having antibodies, like if it is localized form of scleroderma, we see, like we call it CREST syndrome. In that case, we have anti-centromere. And in systemic sclerosis, we call as anti-topoisomerase. In systemic form, we call this anti-topoisomerase. So this localized form is called CREST syndrome, and topoisomerase we see in a patient with systemic sclerosis. Systemic sclerosis. Coming to next antibody, sometimes they can ask you anti-SRP, anti-Jo1, and we have anti-MI2. So these are the antibodies we see in inflammatory myopathies. So we have condition like dermatomyositis and polymyositis. These are basically called inflammatory myopathies. So here, what we can see anti-SRP, anti-Jo1. Then they sometimes ask you, like a person who is having systemic sclerosis overlap syndrome. Whenever you see a person who is having systemic sclerosis overlap, in this case you can see anti-PMSCL, antibody. Okay, so other than this, we have some more antibodies, so let us discuss those. So if I tell you like some other condition, I can say some rheumatological, some non-rheumatological condition. For example, a rheumatoid factor is nothing, it is IgM against IgG. IgM against IgG. So this rheumatoid factor and anti-CCP, anti-cyclic citrullinate peptide, this is seen in a patient of rheumatoid arthritis. So most specific will be anti-CCP, anti-cyclic citrullinate peptide. Then I can say a person who is having some non-rheumatological conditions, like I can say AMA, anti-mitochondrial antibody. It is seen in primary biliary cirrhosis. Whereas P-ANCA is seen in primary sclerosing cholangitis. PBC we also call as primary biliary cholangitis, secondary biliary cholangitis. Primary biliary cholangitis and primary sclerosing cholangitis. Second is due to some obstruction. Then remember anti-Rho, anti-La. Anti-Rho and La, these two antibodies are also called as SSA and SSP. So they are seen in Sjogren syndrome. Anti-Rho is also seen in neonatal SLE. Okay, if I talk about other in liver, if I talk about liver, so we have anti-LKM, anti-LCA, liver kidney microsomal liver cytosolic antibody. Then we have anti-smooth muscle actinin. These are antibodies where we see in autoimmune hepatitis. Then we have anti-GAD, glutamic acid decarboxylase. Then what we have anti-ICA, means islet cell antibody, and anti-ZNT8, zinc transporter 8. So these are seen in type 1 diabetes mellitus. If you see like a person who is having antibodies like anti-GBM, we see in good pasture syndrome. Then you can see anti-TTG and anti-endomycin. These are seen in celiac pro. Then I can say a person who is having Hashimoto's thyroiditis, you will see anti-TPO antibody. And in grave disease, you will see LETs. So these are some important antibodies which we have discussed. So you will definitely get one question in exam. Okay, moving to, they ask you question like which are the murmurs in systole, which are the murmurs in diastole. So understand this, in aortic stenosis and pulmonary stenosis, you will see systolic murmur, and this systolic murmur is called ejection systolic murmur. Ejection systolic murmur. Then in MRTR, what we'll see, murmur. This murmur is called holosystolic murmur. Holosystolic murmur. And in AR and MS, what we see? We see diastolic murmur. So these are some murmurs which sometimes they ask in exam. And if you ask me like mitral valve prolapse, MVP, what we see in MVP? In MVP, you will see a mid-systolic click, and this click is followed by a late systolic murmur. Late systolic murmur, because MVP will ultimately lead to MR. So again, this is like a heart murmur they sometimes ask. So I am seeing like last 2 attempts there is always the question. So I'm expecting they can ask you a question on which is systolic murmur, which is diastolic murmur. So this type of question they used to ask in exam. Okay, moving to a question on antiarrhythmic drugs. So this is like a pharmacology overlap with medicine type of question. I can say like a person. So basically we have a Vaughan-Williams classification that you know. In this classification we can divide antiarrhythmic drugs into 4 categories. So just remember this thing: class 1, class 3, class 2, class 4. So class 1 and 3, these are the class of drug. These are the class of drug which we use in emergency. These are the drugs that we use in emergency because they will have more side effects. So we'll use them in, I can say, unstable patient. So sometimes we use some of these drugs for cardioversion. And class 2 and 4, this class of drug we use in stable patients. So they are used during discharge or in outpatient or during discharge. So these are like those drugs which will have less side effects. So class 2 we have beta blocker. So I can say in class 2 we have beta blocker which will accept sotalol. Beta blocker accept sotalol because sotalol will be in class 3. Class 4 we have CCB. In class 1 we have now we use these drugs very less. So we have drugs like procainamide, right? In class 3 we have widely used class quinidine, procainamide. These are class 1. In 1 we have 1A, 1B, 1C. In class 3 we have drugs like amiodarone, dronedarone, ibutylite. So this is like most common used class in emergency. So if you see these drugs like quinidine will have actually classes of 1, 2, 3 action. Procainamide and flecainide. Remember these 2 drugs, procainamide and flecainide. These are the drugs that we use in a patient with WPW syndrome, Wolff-Parkinson-White syndrome. Then this ranolazine, this question also came in exam. It is a late sodium current blocker. It is basically an anti-anginal drug. Sotalol is having class 3 as well as 2 action. The most common antiarrhythmic drug for emergency is amiodarone. The cognator of amiodarone is dronedarone. And nowadays, we prefer ibutylite because it is considered relatively more safe. Even for atrial fibrillation, we prefer ibutylite. Then they can ask you a question on first degree, second degree, third degree AV block. This will be ECG type of question. So you can see the classical feature of all these heart block. The classical feature that we see is there will be prolonged PR. So if you see a prolonged PR interval, but there is no missed beat. So PR, when I mean PR means it is starting of P to starting of QRS count. That's called PR interval. This is interval. But something which start with something, if I say this duration, ending of P to this, what we call this PR segment. It is called segment. So when I talk about interval means starting of P to starting of QRS. Second degree heart block, understand? In second degree, you will see progressively increase in PR. So PR is increased. You can see progressive increase. Then you can notice something called drop beat. We call this drop beat. So PR prolonged followed by drop beat. In third degree, or I can say the second degree is also called as type 1 or Wenckebach phenomena. This type 2 is called Hayes block. Hayes block. So here you can see like PR will increase, but that is fixed. And you can notice there will be a drop beat. In third degree, you will see AV dissociation. AV dissociation means atrial ventricles, they are moving on their own rate now. Their synchrony is lost. So if you see PR interval, if you here you have to see PP interval. So you can see constant PP interval and constant RR. So RR will be constant, and similarly you can notice PP will be constant. So this is what we call AV dissociation. So understand, in first degree heart block treatment is symptomatic. So it could be due to some drug, some electrolyte imbalance, so that you need to correct. In second degree, we first try temporary pacing. If it fails, then we can switch to permanent pacing. In third degree, irrespective of course, we have to treat this with a permanent implantable pacemaker. So remember, even patient is not having symptom, we have to use pacemaker in third degree. Okay, then this is like a repeat question from 3 attempts. This question they're asking. So you can notice here, you can see a normal or negative Babinski sign. Then here you can notice, we also call this Babinski sign or plantar sign, plantar reflex. So this question like image came in exam 2-3 times in past 2 years. So now what I'm expecting from this topic is they can ask you what is Babinski equivalent. So there are something which we call Babinski equivalent. Babinski equivalent. So when we cannot elicit Babinski, we can use some alternative to Babinski. These are Chaddock sign. On the side part of the foot, you need to scratch with a pen or with a like a point part of a knee hammer. Then we need to squeeze a calf muscle. We call this a Gordon sign. And sometimes we check Oppenheim sign. That is in the tibia. So these are what we call them Babinski equivalent. So they can give you a few more images related to this sign, because Babinski they have asked already. So now this is the expected question. Okay, moving to immunofluorescence pattern, they sometimes ask in exam. Like we can see, this is what we call centromere pattern that we see in I can say Crest syndrome. Then you can see nucleolar pattern. This is a speckled pattern or homogeneous pattern. So mostly in exam, what they try to ask, they ask you either speckled, homogeneous, nucleolar, or centromere. These are the 4 patterns which you have to remember. Okay, they will give a clinical case of anemia. So understand this anemia. In anemia, first thing you have to see is look on the hemoglobin. So hemoglobin will be low. Straight away after this, we need to see MCV. So understand, when MCV is low, so I am just telling you the approach. MCV, if value is given less than 80, if it is given in the range of 80 to 100 or more than 100. So just try to understand this. More than 100 means this will be in B12 deficiency, in B9 deficiency. B12 deficiency, think of history of some, I can say vegetarian diet, or some like atrophic gastritis, intrinsic factor deficiency. B9, sometime remember it can also be seen some liver disease and thyroid disease. 80 to 100, we have hemolytic anemias. So that is normal MCV. You can see hemolytic anemia. Then we can have anemia due to CKD, like anemia due to decreased hematopoiesis, and we can have aplastic anemia. So how we differentiate, understand this. What the question they ask you, what is the next approach? They will give you a clinical case. Then if it is less than 80, here we have Sheetal. Sheetal means sideroblastic, iron deficiency, thalassemia, anemia of chronic disease, lead poisoning. So suppose if MC value is less than 80 is given. In this case, what you will do, you will see MCV divided by RBC count. Make sure RBC count is not the hemoglobin. RBC count is different. Then the CBC you will see RBC count is also written. So RBC count, suppose if you see MCV is given, divided by RBC count. So make a rough calculation. Suppose MCV is given, I can say 60. RBC count is given, I can say 5. So 60 if you divide by 5, this will come 12. So this index came in exam even in last attempt. This index is what we call this Mentzer index. So Mentzer index, if value is less than 13, there is a more chance like person will have thalassemia, and if this index value is more than 13, there is more chance like this patient is having iron deficiency anemia. So this way we need to solve this question. Now understand, lead poisoning will have history of exposure to lead, chronic inflammation, anemia of coronary disease, thalassemia, and IDA you can I can say decode from here. Thalassemia, remember there will be like a child, or there will be like I can say some mention about HPLC or electrophoresis, then iron deficiency and sideroblastic. Sideroblastic will have I can say either genetic mutation due to ALS synthase deficiency, or they can give you like isoniazide toxicity, this kind of thing. Suppose if there is MCV value is given normal and you have to suspect hemolytic anemia, so next thing in the MCQ will be given about reticulocyte count. Here reticulocyte count will increase, LDH will increase, and haptoglobin level will be low. Haptoglobin level will be low. Then additionally, or they can also mention like increase in bilirubin. So bilirubin will increase, patient will have jaundice, these kind of signs will be there. So this is the approach which you need to think before making a diagnosis of anemia. And sometime they can give you like a question on variation of iron study. So that iron study sometime they ask an exam. So just let me quickly make another table to make you understand. So basically you have to differentiate a 3 parameter. This was the question came in last attempt. So I have researched your past 3 years syllabus. Then I made this presentation to teach you only those topics which are asked, and some other topics related to those which can be asked in exam. So basically they want you to differentiate iron study, like they will ask you about serum iron. They will ask you about serum iron, serum ferritin, and they can ask you about TIBC. TIBC is total iron binding capacity. So again here we have to differentiate 3 main anemias. So first will be your IDA, iron deficiency anemia. Then we can have AOCD, and we can have sideroblastic anemia. So understand this. First parameter which will decrease in iron deficiency will be ferritin. So remember, ferritin is stored form of iron, and ferritin is inversely proportional to TIBC. So TIBC will increase. So once ferritin is decreased, then serum iron will decrease. So first to decrease will be ferritin. Coming to AOCD, here all the iron is trapped within store. So stored form will be more, but in the blood it is less, and stored form is inversely proportional to TIBC. Sideroblastic anemia is iron overloaded state. So you can see more serum iron, more ferritin, and here you will notice there will be TIBC will be decreased. So this is the approach to solve a question, because they ask you like what is the diagnosis. They will give you some parameters from like they will give you serum iron, ferritin, and TIBC, total iron binding capacity. Then there is a psychiatry overlap with medicine question. They'll ask you about dementia. They'll ask you about dementia. So in dementia, first thing they can ask you like, do you know most common cause of Alzheimer's disease? That is due to like I can say a neurodegeneration that can occur because of many hypotheses. One of them is tauopathy. So it can occur because of tau proteins. These tau proteins are hyperphosphorylated. They will form neurofibrillary tangles. Then I can say it can occur because of pre-senilin 1 mutation or pre-senilin 2 mutation, or it can occur because of I can say APP, amyloid precursor protein defect, or it can occur because of apolipoprotein. So when we have ApoE4, that will increase the risk of Alzheimer's. But nowadays what they're asking is, they're asking you a differential diagnosis of dementia. So in the MCQ, they will mention patient is having dementia. Then you have to see what else is given. So understand, listen to me very carefully. In the MCQ, they'll ask you dementia plus something else. Then you have to make a diagnosis. So these are the differential diagnosis of dementia. So suppose if they mention like a person who is having dementia, and that dementia is rapid progressive. Rapid progressive means in 6 months there is loss of all memory, and in 1 year patient died. Or they can give you like a person is having history of myoclonic seizures. So when these things are given, the most rapid progressive dementia we see, then answer will be Creutzfeldt-Jakob disease, CGD. Creutzfeldt-Jakob disease. Second thing, in dementia they can mention, suppose they can mention like a person having dementia plus some gait defect, and generally this gait is called wide base gait or broad base gait. So broad base gait we can also see where in cerebellar lesion. Then you can notice like there will be dilated ventricles. So dementia with gait defect and dilated ventricles, it means they are telling you information. This is like a case of normal pressure hydrocephalus. So read the question carefully. Third thing is they can ask you like a person who's having dementia, and along with dementia they can mention you like visual hallucination, and fluctuating cognition. This is like biggest hint. So fluctuating cognition. So what I mean by fluctuating cognition, sometimes patient will be normal. Anyone, any guesses? Fluctuating cognition. What is the diagnosis? This is what we call this DLB, dementia with Lewy body, DLB. Sometimes they will not mention fluctuating cognition, they can mention Parkinson feature, or they can mention Parkinson-like feature, because DLB is the disease which will have feature of both Parkinson as well as Alzheimer. Then they can also mention like a person who's having dementia, and along with dementia you can see like some changes in the frontal lobe, so that's why he's having some personality change. This personality change. So dementia with personality change, this is something what we call as frontotemporal dementia, FTD. So these are the differential diagnosis of dementia. Last attempt they have asked FTD, so this time they can ask you CGD or NPH, very very important. And they can sometimes also ask you like where we see reversible dementia. So remember, in most of the deficiency, so in treatable cause we can see reversible dementia. So where we can treat the cause, I can say in B12 deficiency, even B6 deficiency can cause dementia, B1 deficiency can cause, and B3 like niacin, pellagra, diarrhea, dermatitis, dementia death. So these vitamin deficiency, then remember hypothyroid can cause. Then I can say NPH can also cause reversible dementia. Then any drug toxicity. Some, not all, but some vascular issue like a vein thrombosis or some artery embolic stroke can be reversed. So these are reversible. Neurodegenerative disease like Alzheimer, Parkinson, Creutzfeldt-Jakob, these are irreversible. Neurodegenerative dementia will always be irreversible. So these are differentials of dementia. Okay, moving to next test, they ask you a question on obstructive sleep apnea and obesity hypoventilation syndrome and central tube apnea. So how to differentiate these three questions? So understand this. So obstructive sleep apnea, they will give you like history. A person is obese, he is having daytime sleepiness. So this daytime sleepiness. Then you can notice something called AHI index. AHI index, apnea hypopnea index. Then how to differentiate, like last time many of the students they marked the answer OSA, but in the MCQ it was asked obesity hypoventilation syndrome. So obesity, understand this, OSA patient are also obese. Obesity hypoventilation patient are definitely obese. So here patient BMI is always more than 30. Sometime like a young person who is not obese but heavy smoker, or a person who is having ascites, or I can say a person with some neuromuscular disease. So OSA can be seen in a normal weighted people, but obesity hypoventilation syndrome is seen when BMI is more than 30. Then you can notice, like if you notice the PaCO2, PaCO2 will always be more than 45, means patient will have respiratory acidosis. So BMI is more than 30, PaCO2 more than 45, and there will be some evidence of disturbed sleep. So these things, if they are present, now see, evidence of disturbed sleep you can see in all. But the biggest hint in the MCQs, you have to see PaCO2, you have to see the BMI. When I talk about central sleep apnea, so here mostly they will give you like patients having heart failure. So patients in the case of heart failure. So this is something which you have to remember. Okay, then they ask you question on NN gap calculation. So how we calculate NN gap? So you have to choose sodium value, the sodium value minus chloride plus bicarbonate value. So this is the way to calculate your NN gap. So again, last time they have asked, so I don't think they'll ask you in this time, but maybe you are lucky you get a question on NN gap calculation. Then they ask you question like, again, a clinical case, they'll ask you, tell me, is it a case of asthma or COPD? So basically, they'll ask you a question based on spirometry. So what you have to check in spirometry, understand this. So we have to see FEV1, right? So FEV1 post bronchodilator, if it is increased by more than 12%, from baseline or more than 200 ml. If FEV1 increased by 12% or more than 200 ml above baseline, right? 15 minutes after bronchodilator. 15 minutes after bronchodilator means after beta agonist. So this is like you have to make a little calculation because again this question came twice from past 2 attempts. So there is a chance something they'll ask you related to asthma or COPD. Okay, then this is something which is nowadays people are following a lot. We call this medical nutrition therapy or MNT. So what I mean by MNT, MNT is a type of nutrition therapy that we use, that we give in a patient with who's having diabetes. So understand carbohydrate, fat, and protein. So what we advise a diabetic patient, like you should take when you are eating a daily calories. So out of this 100% of your diet, 50 to 60% should be coming from carbs. Fat you should consume in less than 30%. Less than 30% should be from fat and less than 15% from protein. And even in fat, when you are using, remember we have to use saturated fatty acid. Saturated fatty acid that should be less than 10%. So this is the diet, and along with this, because remember diabetic patient, they are also at risk of hypertension. So salt consumption, you have to remember salt daily intake should be less than 5 grams. So this is the advice that we give to diabetic patient. So see, carbohydrate, fat, protein. We call this medical nutrition therapy. And along with this, if person is walking or brisk walking for 150 minutes in a week. So these are added things which we need in a diabetic patient should follow other than your metformin or OHA, whatever they are using. So we call this medical nutrition therapy. See once again, carbohydrate 50-60, fat less than 30, protein less than 15, and saturated fatty acid less than 10, then salt less than 5. 150 minutes or of brisk walking, or I can say jogging. Now they ask you a question on different drugs for I can say rheumatoid arthritis. So straight away we start with the DMARDs, and DMARD of choice. DMARD of choice is methotrexate. So we can start with methotrexate. If it is not controlled, then we can add HCQS, hydroxychloroquine. We can add sulfasalazine. SARS, the brand name is SARS, or we can add leflunomide. So these are the drugs which we can add. Then for symptomatic relief, we can add NSAIDs. So here I am writing a list of drugs. So these are basically what we call them biologics. So what are these drugs? Adalimumab, golimumab, etanercept, infliximab, certolizumab, abatacept, rituximab. So these are basically acting on your TNF. These are biologics drugs. Some of these are like I can say infusion drugs, so they can precipitate infusion reaction. And anakinase interleukin 1 antagonist. Then we can use tocilizumab, sarilumab, and nowadays we use these drugs very often. These are basically a JAK1, JAK3 inhibitor. So they are even used more than biologics because they are available in oral. So they are oral drugs. MCQ that they ask you, like there are many opportunistic infection which are AIDS defining, but there are certain neoplasm which are AIDS defining. So Kaposi sarcoma, this is most common vascular tumor. So not most common vascular tumor in AIDS patient. Overall, most common vascular tumor will be hemangioma. Then a non-Hodgkin lymphoma, invasive cervical cancer. These are AIDS defining neoplasm. Kaposi sarcoma is caused by HHV8. Okay, then 3 questions which look similar. They sometimes ask in exam. So understand. Alcohol withdrawal. What drug you will use in alcohol withdrawal symptom? We will use benzodiazepines. In alcohol toxicity, what you will use? Alcohol toxicity. We use fomepizole. Fomepizole. Then suppose a person, one more I can say, if a person who is having alcohol addiction, in this patient, alcohol addiction, what I will use? I will use diethylphenol. Anti-craving drugs are the drugs which we add. Which we add means to decrease the craving. So here we have drugs like Nota, mnemonic is Nota, N is naltrexone, O is ondansetron, T is topiramate, A is acamprosate. Acamprosate. Question they have asked in last attempt about which benzodiazepines to use. So remember, benzodiazepine, the preferred benzodiazepine is chlordiazepoxide. Chlordiazepoxide is the preferred benzodiazepine. So the brand name is Librium. But again, sometime you will notice like a patient who is coming with alcohol disease, or I can say for alcohol withdrawal, he will also have some liver damage. In that case, we have to use those drugs which are metabolizing by conjugation, not through liver. So we can use drugs like oxazepam, temazepam, and we can use the MCQ which came in exam, lorazepam. So these are the drugs which are metabolizing by conjugation. We can use in a patient who is having I can say alcohol withdrawal. When like chlordiazepoxide or diazepam, we can't use because his LFT is deranged. Then they ask you some difference between these diseases. You like some differences. Always they ask the path question as a medicine question. So Crohn disease is due to Th1 cells, ulcerative colitis Th2. Smoking and antibiotic use in first year of life is risk factor. Alpha methyl dopa and antibiotic use in first, that's risk factor for ulcerative colitis. Then and you can notice like some gross changes like creeping fat, longitudinal ulcers, cobblestone appearance. Here you can see back vasculitis, collar button ulcers, and pseudopolyps. So I'm not telling you those things like Crohn disease. I'm expecting you are already knowing this thing. Crohn disease can involve any part, and ulcerative colitis will involve only colon and rectum. The most common you will notice here, there will be involvement of ileum, and here you will see most common will be proctitis. Then here lesions are escaped in nature, escape lesion. Here lesions are continuous. And last difference I can say, you already know, like Crohn disease. If you see a person with Crohn disease, the inflammation is transmural, and this is limited to mucosa and submucosa. Now earliest finding here will be aphthous ulcers. Here you will see earliest finding as erythematous mucosa with fine granular surface. Then in like radiological appearance, you will notice rose thorn appearance. You will see lead pipe. Then it can complicate. Complications will be fistula strictures, hemorrhage, toxic megacolon. So these are the complications that we see. Pyoderma gangrenosum and primary sclerosing cholangitis, these two complications are more in ulcerative colitis. Most others are common in Crohn's disease. Then there was a question again, they have asked you like RK39 test, drug of choice will be amphotericin B. Other than this, we can use some drugs like sodium stibogluconate, miltefosine. Patient can have fever with chills, hepatosplenomegaly. So they ask you clinical case and then they'll ask you what drug you will use. That's the case of Kala-Azar. There will be moderate to severe fever with chills and rigors. Where we see central cyanosis, so it is seen in high altitude due to, I can say it is seen in methemoglobinemia, in some congenital heart disease and pulmonary AV fistula. So these are the causes. So they can ask you like all are cause of central cyanosis except this question also came in last attempt. Okay guys, so let us discuss some of the electrolyte imbalance. So basically what is important here, you have to remember what are the electrolyte abnormalities. Then in this, they'll ask you question on what is the normal values, because there will be a bigger question, clinical question. So what are the normal value, and when you will diagnose that condition. For example, hyponatremia is called when sodium value is less than 135. So let me say values, when you will call this. Then they can ask you like what is the cause of death. Cause of death, and ultimately last and the most important will be the treatment part, because in exam they ask you question on treatment part. We have basically we have few I can say electrolyte abnormality which you need to remember. So suppose this table will be extremely helpful to you. So they can ask you hyponatremia. So let me start with hypernatremia, hyponatremia, hyperkalemia, hypokalemia. Then they can ask you question on hypercalcemia, hypocalcemia, hypermagnesemia, and hypermagnesemia. So this type of question they ask in exam. So just try to understand this first. If I start our discussion with normal, when you will label something as hypernatremia. So hypernatremia you will call when sodium values are more than 145. So normal value is 135 to 145, and when this value is more than 158, 158 we call this D. D means dangerous. Similarly, in hyponatremia, you will define this when values are less than 135, and we will call this when I can say this is less than 125. We call this as D. D means dangerous. In both hyper and hyponatremia, the cause of death will be seizures. Patient will develop seizures. This means some CNS issue will occur. Now, understand treatment of hypo part is very simple. So, in hyponatremia, what we can use? This hyponatremia, we can use NS. If it is severe, we can use 3% NS. And I can say whenever there is like hyponatremia due to SIADH, in that case, we will use Vaptan. Sometimes they ask you in old MCQ. In old MCQ for SIADH, we were using demeclocycline. Coming to hypernatremia, suppose generally the patient is unstable. So in that case, what we can use, I can say dextrose, 5% dextrose. If patient is diabetic, in that case, we will use N by 2, means half normal saline, N by 2 or N by 4 we can use. And oral tap water, electrolyte free water. So that is how we manage hypernatremia. Coming to hyperkalemia. So now see, treatment of hypo is very simple. Treatment of hypo is very simple. So in exam, they ask you a question on treatment of hyper. So in hypokalemia, what you will give? In hypokalemia, you will give KCl. If patient is not that severe, then you can give oral Portclor. Similarly, in hypocalcemia, we can use calcium gluconate, right? If it is like a chronic hypocalcemia, in that case, we can give calcium tablet. That calcium tablet is called calcium carbonate. But when we talk about electrolyte, we talk about emergencies. Now, coming to potassium range. Potassium is having a narrow therapeutic range, that is 3.5 to 5. So more than 5, we call this hyperkalemia. But remember, up to 5.5, we call this asymptomatic hyperkalemia. So sometimes patient taking ACE inhibitors, they can develop this type of asymptomatic mild to moderate hyperkalemia. So 3.5, less than 3.5, we call this hypokalemia. Now try to understand this. Whenever you are having a patient who is having hyperkalemia, the cause of death will be cardiac arrest, and this will be a diastolic arrest. Diastolic arrest. And whenever you are having a patient who is having hypokalemia, in case of hypokalemia, patient will develop diaphragmatic palsy, that is respiratory failure. So cause of death will be respiratory failure. So treatment of hypokalemia, you know KCl, but hyperkalemia, how we manage, understand. So first is we can use calcium gluconate. It is the drug of choice. Second, we can use something that can push potassium to go back into cells. So we call this redistribution. In that case, we can use insulin. We can use beta agonist. So you can use salbutamol or albuterol. We can use even diuretics. Diuretics, they will remove potassium. So remember, except spironolactone or other potassium diuretic, we can use all other diuretics, which can, like, especially we use lube diuretic like Lasix or furosemide. Then sometime we can use potassium binders. So potassium binders, we have drugs like SPS, sodium polystyrene sulfonate, sodium zirconate, patiromer. So these are basically binders that we can use. Similarly, in hypercalcemia, now coming to hyper and hypocalcemia, so understand calcium is having a range of 9 to 11, so less than 9 is hypo, more than 11 is hyper. In hyper, the cause of death is systolic cardiac arrest. Systolic cardiac arrest. And in hypo, the cause of death will be laryngospasm. Laryngospasm. So how you will treat a person who is having hypercalcemia? So the hypercalcemia, just try to understand this. So you can, person is having more calcium, so you can give something that can dilute the calcium. So we can use normal saline. Then we can use something that will send calcium back into bone. In that case, we can use calcitonin. We can use steroid, like sometimes patient will develop hypercalcemia due to malignancies or due to, I can say, some autoimmune condition. For hypercalcemia in osteoporosis, we can also use bisphosphonates. Bisphosphonates. So we can use NS, we can use calcitonin, and like older ways we were using gallium nitrate. So gallium is also used. So these are the options available. And lastly, I can say we can use furosemide, not thiazide. Furosemide we will use because it's loop diuretic. This will remove calcium. Coming to hypermagnesemia, so understand hypermagnesemia. If you see hypermagnesemia, we call when magnesium value is more than 2.6, and hypo you will call when values are less than 1.8. In case of hypermagnesemia, the cause of death will be asystole. And in case of hypermagnesemia, the cause of death, I can say this will be due to torsades de Pontes. That's a type of ventricular arrhythmia. So cause of death will be torsades. So again, treatment of hypo part is simple. You are using, in case of hypo, we will use MgSO4. But in case of hyper, we will use calcium gluconate. So you can notice here, calcium gluconate we are using in 3 conditions: hypermagnesemia, hypocalcemia, and hyperkalemia. In all these 3 conditions, it is considered drug of choice. So this is like a quick summary, means what you have to remember. For exam, before exam, about different these type of electrolyte abnormalities. So again, they will frame a clinical case. So you have to remember these normal values as well. So normal value will be like for sodium 135 to 145. For potassium it will be 3.5 to 5, 9 to 11 for calcium, 1.8 to 2.6 for magnesium. This is something which you have to remember. Then they ask a question on like when will be your this question came twice in exam. So in mitral resonance you will see first third sound is loud, but it can become soft in few conditions whenever there is a calcified wall with MR, or a person who is having like a thick chest wall like obesity or an infusion, or sometimes patient with obstructive pulmonary disease, or when you have contractile dysfunction of left ventricle, and even in first degree heart block. So these are the condition where S1 will become soft even when patient is having mitral stenosis. Indication of thrombolysis. So again, they will frame a clinical case. This is a one definite question that will come in your exam. So patient age should be more than 18 years. Patient should come to you in window period of 4.5 hours. So there will be a clinical diagnosis of stroke, and like by CT scan, you have ruled out hemorrhage, or like edema in MCA tertiary is more than 1/3. So that is something like this is these are the indication of doing thrombolysis. So remember, like whenever you will see like patients coming late, like 7 hours, 8 hours, in that case you will not do thrombolysis. There's a window period for mechanical thrombectomy, that is 6 hours. For thrombolysis, it's 4.5 hours. So what I am seeing, like in INI-CET, they are testing your practical knowledge as well. So they are asking question on different classifications for heart failure. So understand, like whenever we see a person having dyspnea, so dyspnea can occur due to respiratory failure or heart failure. So for dyspnea in cardiology, we use NYHA, New York Heart Association, and for respiratory we use MMRC, which is Modified Medical Research Council. So in class 1, understand there is no limitation of physical activity. In class 2, there is some limitation, right? Means rest is comfortable, but some ordinary activities can cause some dyspnea. Class 3, there is marked limitation, and in class 4, means patient will have symptom even at rest. So see once again, no limitation, slight limitation, marked limitation, symptom even at rest. This is what we call NYHA, New York Heart Association. MMRC is Modified Medical Research Council. This is a classification that we use for dyspnea in respiratory system. So understand this thing. Grade 0 means it is like normal people what we have, like dyspnea on strenuous exercise. 1, if I say 1 is like this, it's moving upward. So upward means uphill or while hurrying. Grade 2, understand 2. Suppose if I make a 2 means 2 people, suppose both are 50 years, one is walking slower than another. So dyspnea means I walk slower than people of same age. 3, so 100 is having 3 letter, 1, 2, 3. So dyspnea on getting 100 yard. 4 means floor. So 2, dyspneic to leave the house, or dyspnea while doing normal activities like buttoning, unbuttoning of shirt. Now see, they ask you question on high anion gap. So where we see high anion gap, it is seen in ketoacidosis or ketosis. U is uremia, means AKI CKD patient. L is lactic acidosis. T is toxin. Just remember one more, we can also see this in starvation. So starvation, fasting will have high anion gap. Diarrhea, renal tubular acidosis, and ureterosigmoidoscopy. So these are the causes of normal anion gap. Coming to next thing, they ask you like piperacillin tazobactam. So just remember, out of this question already came. So next time they'll ask you indwelling catheter. So any UTI in diabetes, in male patient, in elderly, in immunocompromised, in patient with indwelling catheter, instrumentation, symptoms I can say more than 7 days, or any functional anatomical abnormality of urinary tract. What we call this as complicated UTI. Complicated UTI. And complicated UTI, remember, we will not treat this with nitrofurantoin or levofloxacin. So in this case, what we recommend to use piperacillin tazobactam. So what we call this complicated UTI. This question already came. Moving to linagliptin. Remember, linagliptin is a drug that is, remember, it is safe in CKD or AKI. But remember, if they ask you a question which drug will prevent CKD or AKI, the answer will become SGLT2 inhibitor. Worst headache of patient life, that is suggestive of subarachnoid hemorrhage, new onset progressive headache. So it could be due to a tumor, due to an evolving tumor, or due to raised ICP, due to papilledema. Headache with a blurring of vision, again it could be due to a tumor. So these are something like, these are those headache, this question already asked an exam, these are those headache which require further intervention. Means these headache should be further examined. So generally like chronic headache or tension headache, migraine, these not to be examined further because diagnosis is clinical. So these are those headache where you'll do further interventions. Proximal flinging movement, ballistic movement, where we see this flinging movement or ballistic movement is seen whenever there is a lesion in hemiballismus. This is called hemiballismus, and this is seen whenever there is a lesion where lesion is in subthalamic nuclei. So this movement is called hemiballismus. We see this in subthalamic nucleus. Then remember, we have other movement like chorea. So C4 chorea, C4 caudate nucleus. So chorea is seen whenever there is damage in caudate nucleus. Athetosis is seen whenever you see damage in globus pallidus and putamen. So remember this gap: globus pallidus, putamen, and A for atherosis, C for chorea. Ballismus, thalamus. Simple. All men are not the same, so we have men syndrome. So remember, we have men 1 syndrome. So it's a rapid recap. So just we are moving a bit fast. I know your time is precious. You have to revise your own notes. So nothing is better than your own notes. So men 1, we have men 2A, we have men 2B. Men 2B is also called as men 3, and even we can have men 4. So men 4 still is not given in standard textbooks. So but some literature they are telling about men 4. So men 1 is basically 3P: pituitary, parathyroid, pancreas. We also call this men 1 as Wermer syndrome. Men 2A is also called as Sippel syndrome. So here we have parathyroid adenoma or hyperplasia. Then we can also have here MTC, means medullary thyroid carcinoma, and pheochromocytoma. In men 2B, we will see MTC, pheochromocytoma, some Marfan syndrome-like feature, Marfanoid habitus. There will be mucosal neuromas, and patient can develop megacolon. This question came in NEET PG exam. So again, this topic is actually NEET favorite, but again, this can be asked in INI-CET also, because sometime like once or twice after 2-3 years, they ask you this type of question. Men 4 is a new topic, that is PPAR: pituitary, parathyroid, adrenal, renal, and reproductive tumor. I repeat, pituitary, parathyroid, adrenal, renal, reproductive tumor. Let us now see some of the images that they can ask in exam and some of the possible MCQs. So remember, temporal arteritis or giant cell arteritis, it is a large vessel vasculitis. So you can see like 3 to 5 centimeter biopsy is needed. So what are the questions they can ask you? Like here you can notice altitudinal hemianopia. Altitudinal hemianopia, and mostly it is seen in people above 60 years. So 60 year or more, that is generally a female. ESR is very high, ESR is more than 60, and treatment will be 60 milligram prednisolone per day. So it's called rule of 60. Then remember, this can also lead to ischemic optic neuropathy, and ultimately there is chance of blindness. This is a vasculitis which is associated with polymyalgia rheumatica. So remember, temporal arteritis is associated with polymyalgia rheumatica. Then they can ask you Takayasu arteritis. So they can give you this classification, like what is the angiographic classification. So we have type 1, which involve branch of aortic arch. Type 2A, ascending aorta, aortic arch. Type 2B, ascending aorta, aortic arch, and thoracic descending aorta. Type 3, thoracic descending aorta, abdominal aorta, renal arteries. Type 4, abdominal aorta, renal arteries, and type 5 combined features. Less than for 50-year-old, less than 49, you mark the answer Takayasu. So Takayasu is seen in young people. And remember, it's also a cause of, I can say, renovascular hypertension. This is pathology test. So you can see positive pathology test, HLA-B51. Then we have recurrent oral ulcers and recurrent genital ulcers. So these are seen in a patient with Behcet syndrome. We also call the Silk Road disease. So treatment will be steroid. Kawasaki disease, patient will have fever, conjunctivitis, strawberry tongue, then risk of MI, lymphadenopathy. Treatment will be aspirin and drug of choice will be IVIG. Kawasaki disease. Berger disease, more in like young male smoker. So you can see this is a disease which start with artery, then it will go to vein, then it go to nerves. So lymphatics are not involved. For treatment, we can use pentoxifylline. Churg-Strauss syndrome, so it is something like which look like asthma. So patient will have asthma-like symptom, eosinophilia, and you can see this rash. Then coming to henoch-Schönlein purpura, this type of photo they tend to ask in exam. It is associated with IgA nephropathy. Then you can see saddle nose deformity in vaginal gallomatosis. Just remember, they can ask you like a nasal carriers of Staphylococcus aureus will have more relapse rate of vaginal gallomatosis. So vaginal spelling I'm changing to C. So C4, C-Anka. Here you will find C-Anka and C4. The drug of choice in this condition will be cyclophosphamide. Cyclophosphamide. This is livedo reticularis, that is like a purple lace-like rash we see in a patient with Upla syndrome. Antiphospholipid antibody syndrome. SLE rash. This is, you can see bilateral parotid swelling we see in a patient of Sjogren syndrome. This is, you can see pale means white, C means cyanosis, R means red, PCR means white, blue, red. White, blue, red, where we see in a patient of Raynaud phenomena. And remember, Raynaud is associated with CREST syndrome. Moving to, you can notice calcinosis cutis. Then we can notice like patients having disappearance, absence of nail folds. So nail folds are not there. We call this sclerodactyly. Then here you can notice acral part. This is expected question. Acral part of bone is, I can say damage. We call this acrosteolysis. Where we see these three findings. I repeat, we see calcinosis cutis, we can see sclerodactyly, and we can see this acrosteolysis in a patient of scleroderma. This is like a tophi that we see in gout patient. Then these are the crystals. You can see needle-shaped crystals, monosodium urate crystals in gout. Then you can notice like calcium pyrophosphate crystals, which are seen in pseudo gout. These are rhomboid shape. This is like overhanging edges with sclerotic margin. We call this Martel sign, and Martel sign is seen in gout patient. Okay, then this is like one of the important image. They can ask you like in rheumatic fever, most common extra articular manifestation will be nodules. Then patient, if it's a male patient, there will be less androgen. Then you can notice like patient will have kidney manifestation like secondary amyloidosis. So most common cause of secondary amyloidosis is rheumatoid arthritis, and that amyloidosis is AA type. Secondary is AA type. Patient can develop cardiac disease, and I can say the cause of death is cardiac disease. There will be pulmonary manifestation. So most common will be pleuritis. Again, it's a very good photograph given in Harrison. There can be xerostomia, secondary Sicca syndrome, keratoconjunctivitis. Again, most common cause of secondary Sicca will also be rheumatoid arthritis. Risk of osteoporosis, vasculitis, and there will be most common anemia, that is anemia of Crohn's disease. There will be cervical myelopathy, means C1, C2 vertebra. So these are some extra articular features that we see in a patient of rheumatoid arthritis. This is, you can see like fingers are divided towards ulnar side, thumb is divided towards radial side. We see where in a patient of rheumatoid arthritis. It is called 1-2-3 sign, 1-2-3 sign or Garland sign, where we see this in a patient of sarcoidosis. Then we have a rash. This rash is called lupus pernio. This lupus pernio is also seen in sarcoidosis. Sometimes they can ask you a question on Gilliam scan. So in Gilliam scan, you can see panda sign or lambda sign. So panda sign or lambda sign in Gilliam scan we see in sarcoidosis. This is called like a chest CT, where you can see like in a patient of hypersensitive pneumonitis, you can notice some ground glass opacity with a mosaic attenuation. So mosaic pattern we see in hypersensitive pneumonitis. Then you can see like here a patient is having like left-sided pneumothorax, S1 Q3 T3 pattern. So you can see S wave in lead 1, Q wave in lead 2. Q means deep, capital Q means deep Q. And inverted T wave in lead 3. We call it S1 Q3 where we see in a patient of pulmonary embolism. Crazy pavement sign. Can you say this? We see crazy pavement sign where we see this in acute silicosis. This is like a bilateral whiteout we see in a patient of ARDS. Then you can see here like a hyperinflated lung, a tubular heart, elevated hemidiaphragm, flattening of diaphragm. Then where we see this is the AP diameter that has increased, we see in a patient of COPD, especially emphysema. Then these are the difference in blue blotters and pink puffers. Just remember like this is and more of an edematous patient. So you can see perioral cyanosis, and here you will see pink puffers. There will be wasting of muscle, cachexia is seen. This is a clubbing, so you have to remember the grades of clubbing because they are asking you practical questions. So remember grade 1, grade 2, grade 3, grade 4. In grade 1 you will see softening, in grade 2 you will see obliteration of angle, in grade 3 you can see parrot beak or drumstick appearance. Parrot beak, or in grade 4 is called hypertrophic osteoarthropathy. And this grade 4 is something that we see in a patient of squamous cell lung cancer. Moving to as we have discussed, they can ask you some breathing pattern, especially they ask on chain stroke breathing and Byers breathing. Small we see in DK patient. So chain stroke, where you can see this in a patient of CHF, and sometimes you can see in a patient of brain stroke. Byers is something that we can see in opioid poisoning and even in CNS disease. Byers breathing. These are red hepatization and gray hepatization in a patient of pneumonia. This is what we call this miliary TB, millet-like granules. Scropholoderma, TB of lymph nodes, Pott's spine. Then this is how we perform Mantoux test. This is like a rough, tough buff colonies. You can see FB smear. Then we have discussed about dementia. You can notice here we can see these are called neurofibular tangles. Just remember these tangles are directly proportional to severity. So more the tangle, severe will be the disease. We call this hot cross bun sign. Hot cross bun sign we see in a patient of MSA. MSA means multisystem atrophy. It's the type of Parkinson plus syndrome. So in Parkinson plus syndrome we have MSA. We have dementia with Lewy body. However, it is not given in many books. MSA, DLB, corticobasal degeneration, and progressive supranuclear palsy. These are 4 conditions. So out of this MSA-C, MSA is having some type. MSA-C means cerebellar feature. MSA-P means Parkinson feature. So MSA-C type will have C4 crossbun. MSA-P type will have putamen rim sign. We call this hummingbird sign. So hummingbird sign we see in a patient of PSP, progressive supranuclear palsy. Eye of tiger appearance, understand. This is a case of secondary Parkinson. We call this Haloverden-Spart syndrome. Haloverden-Spart syndrome. Then sometimes you can see this panda sign, face of giant panda, we see in a patient of Wilson disease. Then here you can notice like pallor of substantia nigra we see in a patient with Parkinson disease. Sometime in Parkinson you can see one more sign called in MRI. In MRI you can see loss of swallowtail sign. Then these are different type of multiple sclerosis. So understand this, this type of image is sometime asked in exam. So we have relapsing remitting type. We have primary progressive type, then we can have secondary. So out of this, remember, most common type will be relapsing remitting type of MS. Karnick's and Buzinski signs, again I am expecting some clinical MCQs, practical based MCQs, we see in a patient of meningitis. Then the technique of doing lumbar puncture in lying position and sitting position. This is an LP needle. So we have to Whitaker and Sprotte needle. Whitaker and Sprotte needle. This is like autologous blood patch. You can see the direction here. These are like giving hands, how we give. If it is like if we are taking CSF, our hand movement will be like this. So we call this autologous blood patch. Autologous blood patch is something which we do to patient who is having persistent headache after lumbar puncture. Then you can notice like here how we differentiate. This is like a patient of subdural hemorrhage. This is a case of epidural hemorrhage. You can see here bleeding near Sylvian fissure. This is a case of subarachnoid hemorrhage. Then we have circular phyllite. So you can see this is ischemic, and ischemia means there will be like a less blood supply to this area. Hemorrhagic means there is bleeding. Now understand, based on GFR, we can calculate G1, G2, G3. These are stages, and G4, G5. So in G1, G2, G3, our treatment is supportive or symptomatic treatment. So you have to give supportive or symptomatic treatment, means symptomatic, whatever symptom that need to be treated. In G4, G5, the treatment is dialysis. Dialysis, but the best will be transplant. These are stages of CKD. So what we do in G1, G2, G3, that I'm telling you here. In G1, G2, G3, we have a mnemonic A, B, C, D, E, K. A for A1C. A1C means tight sugar control. B for BP control. C for cholesterol control. D for vitamin D. E for, what is E? So understand, E here will be erythropoietin recombinant form, and K means vitamin. K here is kalemia correction. Sorry, K is kalemia, means potassium correction. So most patient will have some problem. There is hyperkalemia, so that need to be corrected. Okay, then there is something which they test in almost every once or twice, like I can say every year. You can see there's a question from this photograph. So they'll ask you like sometimes they can ask you IgG, IgM. So these are the like they will give you an image based question, and they'll ask you need to mark what is the antibody. So you can see HBS antigen, then we have IgM anti-HBC. So this will start appearing in 4 weeks. I think this was the question came in last attempt. Similarly, they can ask you like wild type chronic hepatitis B. So appearance of ALT, then HBE, HBV DNA. So these are the questions like which marker is present on weeks or months after exposure. Then we have classification of Hodgkin lymphoma, like this is nodular lymphoma. This is what we call, let me make this simple. This classical type, in classical type we have nodular sclerosis, lymphocyte rich, mixed cellularity, depleted. And this is what we call this predominant type. This is called atypical type. So we can divide this into classical, and this is called non-classical type. Non-classical type. This is called feline esophagitis. You can see multiple corrugated fold. Multiple corrugated fold, we call this corrugations. So this is basically eosinophilic esophagitis or feline esophagitis. And once you start treatment with steroid on time, there will be a good response. Acanthosis nigricans, this is called scleredema. It is not scleroderma, scleredema. Then you can notice here there will be shin spots in the tibia. And this type of rash, we call this granuloma annulare. Granuloma annulare. So this is something which we see as a sign of diabetic dermopathy, diabetic skin changes. So this is something like they ask again and again. So you can see like a normal, you will see a normal uptake, bilateral increased uptake we see in Graves' disease. If you see like it is a random uptake or unequivocal uptake, we see in toxic multinodular goiter. But if you see more of a central uptake, that is seen in a patient of toxic adenoma. This question came in one attempt before. Then you can see peritibial myxedema and nail changes. This nail changes what we call this acropathy. We call this thyroid acropathy. So these are changes seen in a patient of hyperthyroidism. This is myxedema. And this is like ophthalmopathy. Okay, then some genetic part, they can ask you Down syndrome. You can see like this karyotype, you will see trisomy 21. There will be like a saddle toe, gap between toe and first finger. Then you can see single palmar crease, right? And you can notice like there will be upward slanting eyes. They can ask you Turner syndrome. There will be short height, widely spaced nipples, shielded chest. Then there will be, I can say, nevi formation, rudimentary ovaries, or I can say streak ovaries or empty ovaries. So that's why they will not have their own kids. Coarctation of aorta and cubitus valgus, that is elbow deformity. So these are changes in Turner syndrome. And remember, we don't have a bar body here because karyotype is exo. If you compare this with Klinefelter, you can notice like female-like feature, testicular atrophy, female-like pubic hair pattern, female-like body hair, impaired IQ, tall height, right? Poor beard growth. And both will have both will have, I can say, hypergonadotropic hypogonadism. Because in both the case, like testosterone and estrogen are less, this will give a feedback to pituitary. Pituitary will release more FSH. We call this hypergonadotropic hypogonadism. So this is a karyotype of Turner syndrome. So I think we have revised one of the images, including genetic images. You can see mother is affected, all babies. Mother is affected, all babies. Father, no one. Mother, all. Father, no one. For mother, all. Father, no one, we call this mitochondrial inheritance. This is not the baby, this is baby-in-law. This is also baby-in-law. This is the chikungunya rash. You can see a peculiar rash at the nose tips or some area of lips are involved. We call this chikungunya rash. Kingi-Mingi hair disease or Menke syndrome, it is due to ATP7A gene mutation. Differential diagnosis will be Wilson disease. Swan neck, you can see flexion of DIP, we see in a patient of rheumatoid arthritis. Then this could be asked in exam. So they ask you like we have different type of insulin, like this proless part, glulysin short acting, regular and PhDs are intermediate acting. Then we have Detemer, Glargine, and even bigger than this, what we have Degludec, that is having even a T half of 48 hours. So Glargine, Detemer, Degludec, these are long acting insulin. They ask you a question like which is a peakless insulin. So this Glargine is something which is not having a peak. We call this peakless insulin. Then look at, like, let's see some of the important ECG. You can see like there is a narrow QRS and no P wave. Narrow QRS and no P wave. We see this where in a patient of atrial fibrillation. If you see here a slurry rise in initial portion of QRS. This slurry rise in initial portion of QRS, we call this delta wave. It is called delta waves, and delta waves are seen where? In WPW syndrome. And you can see like patients having delta waves, that is slurry rise in upstroke, initial portion of QRS. Then here you can see like P is followed by QRS, PQRST. There should be P, but there is QRS. So this is called an extra ventricular contraction. We call this PVC, premature ventricular contraction. If you see here like regular RR interval but broad QRS, we call this VT, ventricular tachycardia. Then you can notice more than three different pattern of QRS. We call this torsadus de pontes. It is something that is seen in hypomagnesemia, which means there we have to give MgSO4. Here you can see we don't notice P or QRS, unidentified QRS. We call this ventricular fibrillation. Then this is again, you can see progressive increase in PR. PR is progressively increased. There is no missed beat. This is your first degree epiplon. Then this is a chiroarthropathy or namaskar hand. We see like sometime in a patient who's having diabetes. So this image once came in exam, chiroarthropathy. Remember, you will just, this was like a rapid review of all the important images and topics which came in past 2 years in INI-CET, 2 to 3 years. So this is very, very important. Just watch this video once before exam. I hope you all will have a decent score and you'll get your dream branch. Thank you so much. Keep working hard. Bye-bye.